You know, it's wild how sometimes your body's own defenses can just, well, go haywire.
Mm,
Take eosinophilic granulomatosis with polyangiitis. It's quite a mouthful. Right.
it really is. Most people probably knew it as Churg-Strauss Syndrome before.
Exactly. And imagine a condition that, seems to pop up maybe just as asthma or allergies initially,
Right.
but then it can actually go on to affect all sorts of organs. That's what we're diving into today.
Yeah, absolutely. And our mission, really, with this deep dive is to get you up to speed on the key things, the essentials of EGPA, using the information we pulled together.
Sort of a quick start guide.
Exactly, to understanding this pretty complex condition.
Okay. So in this, let's say, concise exploration, we're going to break down what EGPA actually is, what might set it off, who it tends to affect, how it develops in the body, the clues doctors look for, what else it might be mistaken for.
Yeah, the differential.
Right. How common is it, those telltale signs and symptoms, how it's diagnosed, managed, what the future might hold, and potential complications too.
That's good.
So let's kick things off. What is EGPA, sort of in a nutshell?
Okay, so at its core, EGPA is a rare autoimmune disease. And remember, autoimmune just means your body's immune system gets confused and attacks healthy tissues by mistake.
Right.
In EGPA, this leads to something called systemic vasculitis. That's inflammation of small to medium-sized blood vessels basically all through the body.
Systemic meaning it can have really wide-ranging effects then.
Precisely.
Yeah.
And the key features, the hallmarks, are eosinophilia. That's a high level of a specific type of white blood cell, the eosinophils.
Okay.
And the fact that it often involves multiple organ systems, particularly the lungs, skin, heart, and the nervous system.
And you mentioned its frequent link to asthma?
Yes, that's a really common connection. It's also often what we call ANCA-associated. ANCAs are specific antibodies that can sometimes mistakenly target your own blood vessels.
Little flags gone wrong?
Kind of, yeah. And this inflammation can affect blood flow in lots of different places. Coronary arteries in the heart, pulmonary in the lungs, cerebral in the brain, abdominal, skin vessels.
Yeah.
It's quite widespread.
Wow. Okay, so what could possibly trigger this kind of, well, widespread reaction? What are we looking at for causes?
Well, that's the tricky part. The exact cause is still, honestly, a bit of a puzzle. It's likely a combination of things. Maybe some genetic predisposition, making someone more susceptible.
Right.
And then environmental factors acting as triggers. Things like allergic reactions, maybe specific allergens, possibly even certain medications have been suggested.
So it's almost like the immune system gets its signals crossed somewhere along the line.
That's a really good way to think about it. There's definitely an abnormal immune response happening involving those eosinophils we mentioned, and other antibodies too. And interestingly, we have seen reports where certain drugs, things like mesalazine, propylthuracil, and even some leukotriene and receptor antagonists, which are sometimes used for asthma.
Oh, wait, asthma meds.
Yes, they've been linked to triggering EGPA in some individuals. It's not common, but it's reported.
That is a surprising link. Are there specific things then that make someone more at risk? Any clear risk factors?
Not really any definitive ones, no. EGPA can affect people at pretty much any age, although it is more often diagnosed in adults.
Okay.
There seems to be a slight tendency for it to be a bit more common in males, but it's not a huge difference.
Right.
And while, yes, a history of asthma or allergies is often present, it's definitely not a universal rule. And as we just mentioned, those leukotriene receptor antagonists, well, they've been implicated as potential triggers in some specific cases.
Okay, so we have an idea of what it is, what might contribute. How does EGPA actually, unfold in the body? What's the typical progression like?
It seems to develop in roughly 3 phases typically. First, there's what's called the allergic phase.
Okay.
This often presents as asthma, maybe new onset or worsening, or allergic rhinitis, hay fever type symptoms.
Familiar stuff.
Yeah. Then comes the eosinophilic phase. This is where we see that rise in eosinophil levels in the blood, and these cells actually start to infiltrate various organs.
Ah, okay.
And then finally, the vasculitic phase emerges. This is where the real inflammation and damage to the blood vessels occur, and that ultimately leads to organ dysfunction and the clinical signs and symptoms we start to see.
So it's almost like a 3-act play then? Starting with allergies, building up the eosinophils, and then the blood vessel inflammation hits.
That's a pretty good analogy, yeah.
So what kind of symptoms and signs might someone with EGPA actually show? It sounds like it could be quite diverse.
Oh, it absolutely can be. Very varied. It really depends heavily on which organs are being affected.
Right.
Common symptoms definitely include asthma, allergic rhinitis, and that high eosinophil count we keep mentioning, But also things like nerve damage, especially in the limbs, peripheral neuropathy. Skin rashes are common too. Sinus issues, lung involvement beyond just asthma, heart problems, gastrointestinal symptoms, even kidney involvement. And it's also characterized by periods where symptoms might ease up, that's remission, and then flare up again, which are relapses.
Okay. And what might a doctor actually see during an examination or maybe in tests? What are the signs?
Yeah, so key signs would include that blood eosinophil count being really high, like over 10%, inflammation of the sinuses, paranasal sinusitis, a specific nerve issue called mononeuritis multiplex.
What's that exactly?
It's damage to several individual nerves,
Yeah.
often causing weakness or numbness in different, seemingly unrelated areas. And the presence of certain antibodies, specifically p-ANCA, in about 60% of cases.
Okay.
Then you have the organ-specific signs. Lung involvement can range from asthma to pneumonitis, even coughing up blood sometimes.
Right.
Upper respiratory issues like nasal polyps are common. Heart issues could manifest as heart failure, myocarditis.
Inflammation of the heart muscle.
Exactly. Or even myocardial infarction, a heart attack. Skin problems are frequent small purple spots called purpura, skin nodules.
Yeah.
Sometimes more severe things like necrotic bullae or digital ischemia.
Reduced blood flow to fingers or toes.
Right. Kidney involvement like glomerulonephritis. Peripheral neuropathy we mentioned, but also potentially stroke or eye involvement. Gastrointestinal symptoms can be serious vasculitis. There can cause bleeding, bowel ischemia, even perforation.
That sounds dangerous.
It can be. Plus, you might see liver dysfunction and then more general symptoms like just feeling unwell, malaise, fatigue, weight loss, fever, muscle aches, joint pain. It's a really wide array.
Gosh, yeah. With so many possibilities, what else could be going on that might look like EGPA? What's on the differential diagnosis list?
That's a really crucial question, especially for clinicians. You need to consider other types of systemic vasculitis, both primary ones and those that are secondary, may be caused by another condition.
Okay.
Certain infections, especially parasitic worms like helminths or nematodes, can also cause high eosinophil counts, so those need ruling out. We also need to think about primary hypereosinophilic syndrome, another disorder defined by high eosinophils, but without the vasculitis usually. And importantly, you have to consider malignancies, things like leukemia, lymphoma, myeloproliferative neoplasms, even some solid cancers can sometimes present with eosinophilia.
So a lot to rule out. It's not always immediately clear-cut then.
Definitely not always.
How common is EGPA? What do the numbers tell us about its epidemiology?
Well, it's definitely considered a rare disease. While we don't have super precise UK figures, the estimated number of new cases each year, the incidence is quite low. Probably somewhere between 0.5 and maybe 2.4 cases per million people per year.
Wow, that's tiny.
It is. Worldwide, the total number of adults living with it at any one time, the prevalence, is estimated to be around 10 to 14 per million adults.
Okay.
The average age when it starts or is diagnosed is typically around 40 years old. But honestly, it can occur across a really wide age range, from childhood up to older adults.
And gender.
Interestingly, it seems to affect men and women roughly equally. No significant difference there.
So rare, but obviously very significant for those affected. How do doctors actually diagnose EGPA? Are there specific criteria they look for?
Yes, there are diagnostic criteria that help guide clinicians. The original ones, the ACR criteria from 1990, looked for someone to have at least 4 out of 6 specific things.
Okay, what were they?
They were asthma, having that eosinophilia over 10%, paranasal sinus issues, lung infiltrates seen on imaging, histological confirmation, so looking at tissue under a microscope, showing vasculitis with eosinophils outside the blood vessels, and that nerve damage pattern, mononeuritis multiplex or polyneuropathy.
4 out of those 6. And have those criteria evolved over time?
They have, yes. There's a more recent scoring system developed by ACR and ELR, the European League Against Rheumatism. This assigns points to different findings.
How does that work?
Well, for instance, having a very high eosinophil count, like over 1 billion per liter, gets you 5 points. Obstructive airway disease, like asthma, gets 3 points. Nasal polyps also get 3 points. Interestingly, having certain types of ANCA antibodies, like c-ANCA or anti-PR3, actually subtracts 3 points, because those are more typical of a different type of vasculitis.
Ah, okay. That helps differentiate.
Exactly. Finding eosinophilic inflammation in a biopsy gets 2 points. The mononeuritis multiplex gets 1 point. Finding blood in the urine, hematuria, subtracts a point.
So you add and subtract.
Right. And if the total score is 6 or higher, along with evidence of vasculitis either clinically or on biopsy, it strongly supports an EGPA diagnosis. These criteria, combined with the whole Clinical picture, lab results, imaging, and sometimes biopsies are really key.
That scoring system sounds pretty useful. So what kind of specific investigations would a doctor typically order then? Maybe we can use a memory tip here, like BBBIA.
Oh, I like that. BBBIA. Let's see. Blood tests are absolutely crucial. Checking the full blood count for the eosinophil level, inflammatory markers like ESR and CRP, and those ANCAs.
Okay, first B is blood.
Right. Second B could be biopsy. Taking a small sample of affected tissue, maybe skin, nerve, or lung, can be really helpful. Looking for those characteristic changes, the vasculitis with eosinophils.
Makes sense. Third B.
Let's say bronchial investigations. So maybe a bronchiolar lavage during a bronchoscopy, washing cells out from the lungs. That might show high levels of eosinophils too.
Okay, blood, biopsy, bronchial.
For imaging,
Sure.
definitely.
Yeah.
Chest x-rays, or more commonly now, chest CT scans, are vital to look for lung abnormalities, infiltrates, nodules, that sort of thing.
Got it. And A.
Additional tests. This really depends on which organs seem to be involved based on the symptoms and signs. So maybe an echocardiogram for the heart, nerve conduction studies for neuropathy, kidney function tests, urine tests.
So BBBIA, blood biopsy, bronchial, imaging, additional. That's a good way to remember the key investigation areas.
Yeah, I think that works pretty well.
Okay. So once someone is diagnosed, how is EGPA typically managed? What's the treatment approach?
The main goals are really threefold. Control the inflammation, prevent further organ damage, and minimize the symptoms to improve quality of life.
Makes sense.
The usual approach involves corticosteroids, like prednisolone, often started at quite high doses initially to get the inflammation under control quickly and then gradually tapered down.
Okay, steroids are key.
Definitely. And often, especially if there's significant organ involvement or it's more severe, immunosuppressants are used alongside the steroids or as steroid-sparing agents.
What kind of immunosuppressants?
Medications like cyclophosphamide were historically used for severe cases, though less now due to side effects. Azathioprine or methotrexate are common for maintaining remission.
Right.
And more recently, biologic therapies have become important. Rituximab can be used, and particularly mepolizumab, which specifically targets a pathway involved with eosinophils, has shown good results, especially for difficult-to-treat or relapsing cases.
So newer options are available too.
Yes. There are other options sometimes considered, like immune globulin, interferon alpha, plasma exchange in very specific situations, maybe even things like tacrolimus or omalizumab in refractory cases. And of course, regular monitoring is absolutely essential to track progress and adjust treatment.
Okay. What's the general outlook then for someone diagnosed with EGPA? What can they expect long term? What's the prognosis?
It really varies quite a bit. It depends heavily on which organs are involved, how severe the involvement is, and crucially, how quickly it's diagnosed and how well they respond to treatment.
So early diagnosis is key again.
Absolutely vital. Early diagnosis and effective management significantly improve outcomes and help prevent irreversible organ damage and complications.
Right.
Long-term remission is certainly possible for many people. However, relapses, unfortunately, can occur, sometimes years later. So consistent monitoring and sticking closely to the agreed treatment plan are really key for long-term management.
And the survival rates.
Historically, before effective treatments like steroids, the outlook was quite poor. Maybe only 25% 5-year survival, but now with timely treatment, that's dramatically improved, often up to around 90% or even higher.
That's a huge difference.
It really is. But certain factors can indicate a potentially poorer prognosis. Things like significant proteinuria, suggesting kidney damage, renal insufficiency, cardiomyopathy affecting the heart muscle, major GI tract involvement or central nervous system involvement. Those tend to be markers of more severe disease.
Okay, good to know. And what kind of complications can arise if EGPA isn't diagnosed early or isn't well controlled?
Well, the main complications stem directly from that ongoing inflammation and damage to the blood vessels in various organs.
Right, the vasculitis itself.
Exactly. So this can lead to serious and sometimes permanent problems like heart failure, chronic nerve damage causing persistent pain or weakness, neuropathy, renal impairment possibly progressing to kidney failure, and lung fibrosis or scarring.
So significant long-term issues.
Yes. And it's also important to remember the other side of the coin. The treatments themselves, particularly long-term high-dose corticosteroids and potent immunosuppressants, can have significant side effects and increased susceptibility to infections.
A balancing act, then.
Very much so. That's why, again, early diagnosis, appropriate intervention tailored to the severity, and careful ongoing monitoring are just so crucial to try and minimize both the disease complications and the treatment-related risks, ultimately improving those long-term outcomes. Serious cardiac and neurological complications especially are more likely if diagnosis is delayed.
Okay, that makes a lot of sense.
So just to wrap up this quick deep dive into EGPA, remember it's that rare autoimmune condition. Key features are high eosinophils and blood vessel inflammation, the vasculitis, often linked to asthma and allergies.
Right.
Diagnosis relies on those clinical criteria, blood tests, imaging, sometimes biopsies, remember BBBIA.
Got it.
Management typically involves steroids and immunosuppressants, sometimes biologics like mepolizumab now. And crucially, early treatment really does significantly improve the outlook and helps prevent those serious complications.
It really highlights just how complex these autoimmune conditions can be, doesn't it? The way the body can turn on itself.
Absolutely. It's a fascinating and challenging area of medicine. And for anyone listening who wants to delve deeper or needs resources for revision, especially for exams like the MSRA, be sure to check out paththemsra.com and also freemsra.com.
Great resources. Thanks for breaking that down for us.